All right, go. Okay. Good afternoon, everyone. This is Jerry Schmidt. I'm here at HSCRC offices. With me today are Ellen Engler and Brian Morton. We also have Mike Robbins and Tracy Laval out at MHA with some other people joining us on this webcast today. What we intend to do today is to speak to you a little bit about what we're planning to do in the near future regarding the update of all hospitals' rate orders. On our agenda today, we're going to first talk about a little bit about the procedures for the initial update that we're going to be sending to hospitals who are on the GBR and the TPR. This would be for fiscal year 15. We're going to talk a little bit about the new GBR TPR model that we're eventually going to be using to update rates. We'll talk about GBR TPR 2, which is one of the worksheets within the update model, and that's probably going to be the most important worksheet that you guys will need to familiarize yourself with. And then finally, we'll talk about what we're going to be doing in the future and when we will be issuing our final rate orders. As far as the current procedures and what we're going to do, we intend to, in the next couple weeks, to send out something to the hospitals that will be the basis of their new GBR for the upcoming year. It'll include all adjustments that we will be making except for any settle-up for the fiscal year 2014 GBR agreement. That will take place in the future. Unit rate penalties, okay, will also not be included in the in this adjustment at this time. What was that? Yeah, we're going to be doing the same thing for the GBR as we are for the TPR. So basically, when I say GBR, I will be referring also to TPR adjustments at that time. What we will be doing, we will not be sending out a rate order right now. We will, however, be sending out a notification to each hospital CEO and CFO, and they'll be giving you the initial GBR, TPR revenue for this fiscal year. We'll also be providing you with a target for the 6-month ending December 31st, 2014. Because we are, our new waiver test is based on a calendar year basis. We are trying to ensure that we hit the targets that we are that we've set forth for this calendar year. One thing we do want to remind hospitals is the existing rate orders will remain in effect, and what you're meant to do is to adjust those rates in order to hit the revenue that's going to be put out in the near future. As I said, we're going to be using a new model this year since everybody basically is on either a GBR or a TPR. This model will basically be the TPR model from the past. You will find that it'll be much simpler than the model was previously. There'll be much fewer worksheets. At this time, there's probably about 4 worksheets that we're going to ask you to focus on. The first one will be an input sheet, which will have the current rate order, will have update factors, and other information. Most of that will be self-explanatory. There will be a GBR TPR 1 that actually calculates the difference between what your actual revenue was for the year and the GBR or TPR target that was approved for you for that period of time. That will not be completed at this time. It will be done, though, in the near future when the data is available. GBR TPR 2, and this is the crux of what we're going to be talking about today, that calculates the new approved GBR TPR revenue for fiscal year 15. It'll include, again, everything except for the settlement that we will be doing of the actual versus the target for fiscal year 14. There's one other page that we're going to be looking at, and that's the markup calculation. And this will adjust for the difference between the statewide average last year and the statewide average this year. It will take into consideration the reduction in uncompensated care because of the Affordable Care Act. That was put out in a paper that was released some time ago, so every hospital should have an idea of what the reduction in their bad debts will be. It basically is looking at reducing bad debts for the expected impact of PAC people being added to the Medicaid rolls. But because of medical assistance is now going to be paying for these people, you will have to be providing them a discount, additional discount of 6%. The reduction then has been, the reduction that we've made to uncompensated care will be added to the Medicaid expected revenue, and that will be adjusted for so that you will be able to provide the 6% differential to the to medical assistance. You're going to have, we will be making the adjustment to your PDA schedule for fiscal year 13, and so you all will need to take into consideration that adjustment and ensure that it's made correctly. Moving on to the TPR2 adjustment worksheet, which we believe is probably going to be the most important one, and I don't know, I think this is so much simpler than before, and that it won't take us long to go through this, but basically what we do is we start out with the currently approved GBR or TPR revenue, which is included on your contract for most of you guys. The first thing we do is we reverse the one-time adjustments that are included in those current GBR, TPR revenue contracts. They've all been listed for you, and those numbers should be known to you at this time. The next thing we do, we'll be making the adjustments, all the permanent adjustments. Those permanent adjustments will take into consideration the update factor that was approved by the Commission. That update factor will be reduced by the net change in the shared savings adjustment. And so in the past, last year, the overall adjustment for shared savings was an approximate 2.2% offset to the update factor. This year it was increased to 0.4%. What we will be doing is looking at the difference between last year and this year, and that will become an additional adjustment to the update factor for this year. After that is applied, we will also be looking at the change in the markup. Those markups were adjusted last year to take into consideration the change for last year. There wasn't a change for last year, so it should be the markup that you had in rates from the year before. That shouldn't be a problem. The next thing we will be adjusting for is the population demographic adjustment. That number was recently sent to all of you by Shule, and those are the numbers that are currently going to be used for the TPR hospitals. The adjustments that we'll be using for population are those that were included in their previous contract, so they have opted for not changing to the new numbers. Then we will be making an adjustment for any other permanent things that need to be adjusted for. One of those for a number of hospitals will be additional money for healthcare population infrastructure. Another adjustment that might be made could be for capital or any other permanent adjustment that's been agreed to between the Commission and the hospital at this time. That will give us then the total new permanent GBR, TPR revenue that will be approved for fiscal year 15. And now we will start adding back all the one-time adjustments and reverse that need to be made this year. And so they will basically be all of the assessments that need to be made, which are the Maryland Health Care Fund, the Deficit Assessment Fund, the MHIB Fund, HSCRC fees, MHCC fees, patient safety, NSP1, NSP2, newborn testing. In addition, we will be making one-time adjustments for quality, and they will include the MHAC adjustments and the QBR adjustments. The QBR adjustments may not be made at this go-round. They may not be available, so we'll actually include them in the final calculations that we make later, okay? The user fees will be in there, HSCRC and the MHCC user fees. What?
MHCC maybe later.
Oh, and I was just told that MHCC user fees may not be available within the next week or so, and we intend to put these orders out. So as soon as they are available, we'll try to get them in, and if they don't go in at this time, they will go in the future. Okay, and we will probably include last year's number as just a placeholder. So that is the main thing that we would be doing. Once we complete this, we will actually send out to you, we will send out you a notification of what your new GBR revenue will be. The initial GBR revenue will be. Again, this will not include any settlement for fiscal year 14. You will also be sent out a mid-year target that will basically be 50% of the total revenue. A few of the hospitals have negotiated a seasonality adjustment, and so those seasonality adjustments will be made for those few hospitals. But otherwise, it will basically be 50% of the current approved revenue. We will expect you to be in compliance with these mid-year targets by the end of December. And again, this is important to us because we are trying to hit these targets that have been agreed on with the overall targets have been agreed on with CMS. Mainly, we are trying to ensure that hospitals do not go over this. I know that our executive director said that, you know, if hospitals are slightly under, that's okay, but she doesn't want it over. The remainder of the money that would be approved hospitals will be allowed to generate that over their final 6 months of the GBR agreement. Right now, there are no penalties or anything in place for not meeting the mid-year targets, but the staff will determine whether we are going to need to do something about that in the future, depending on how the industry responds this year. So if we find that, you know, hospitals were complying and trying to do a good job of being in compliance with these mid-year targets, we will continue to go like we are. If not, then we may need to do something different for the future. Okay. What will we be doing? This is what we intend to be doing now. So within the next week or so, we intend to be sending something out to the hospitals that will include all these adjustments. We'll ask the hospitals to look at those quickly, and if they believe any problems exist, they need to respond to us very quickly, because after we send that out to you, we will be notifying you within probably a week or so of what your initial target is, okay, along with the mid-year target. So the hospitals will need to focus on this when it is sent to you, and they will not be able to wait, you know, a week before you start looking at this. We need you to start doing it right away and start complying with it right away. Once that's done, we will still be looking at, you know, anything else that we may think needs to be done for the final, before we put out a final rate order. One of the things that we will be looking at is whether we will do the rate realignment for this year based on the fiscal year 13 cost report. We basically will be trying to determine what impact doing a rate realignment would have on the Medicare waiver in addition to the overall. and then trying to ensure that that would not be a problem for us. Once that's determined, the hospital industry will be notified. As soon as the data, the final data for fiscal year 14 is available to us, we will take that data, we will calculate then what the settlement is for fiscal year 14. We will be able to incorporate that hopefully into the model and quickly turn around and send out a model to you which you can then look at. We will then determine, before that we will have determined whether we are going to do rate realignment, and if we are going to do rate realignment, that will be included in the model at that time. Finally, we will be looking to issue a rate order effective July 1st of 14. We're looking to be doing that in mid to late August, and that may also include a final target for the for the period ending December of 14. So I believe that is most of the stuff that we wanted to talk about today. We wanted to remind you that there's some supporting documents will be put on the website after July 7th, 2014. They will be at www.hscrc.maryland.gov, and there will be something on there for all these different assessments that will need to be made. So hopefully you'll be able to see them very shortly and look at those relative to, compare those to the numbers that you will be that will be included in the update that you will have received. So with that, I'm going to open it up to questions and see if anyone, if I can answer questions for anyone.
I'll see if she has it open for Mike and all. Right.
Tracy?
Yes, I think we do have a question. Can you hear me?
Yes, we can hear you.
Oh, good.
Hi, this is Beth Kelly. I was just wondering how will compliance be handled for July through December from a unit rate perspective?
July through December, we are going to be focused again on the compliance for the mid-year target. It's going to be set for you. You have a set of rates, so you will be needing to adjust those rates up or down in order to hit those targets.
Are there corridors?
The corridors as they are in your current agreement, which plus or minus 5% for all revenue centers with approval plus or minus 10.
Right, thank you. Is that on a monthly basis or a quarterly basis?
Monthly.
Got it, thank you.
Okay, additional? Who wants to go?
Oh,
Here you go.
Sarah, keep it.
This is Derek Carlos from MedStar. Is case mix going to be factored into the updates at all?
At this time, case mix will not be factored into the updates unless you're going to charge per target, which I don't believe anybody will be after July 1st of this year. However, though, we will be calculating case mix change in the future. Case mix will be used for a number of different things, and so Andy will be developing some weights and putting them out. They have not been developed to my knowledge at this time, but the case mix index, at least at this point in time, will not be considered during the calculation of this update factor.
This is Rich Pellegrino from Calvert. With respect to the answer regarding unit rate compliance from the question ago, currently within our agreement, and granted we are a TPR hospital, this is our 4th year, we did not have monthly unit rate compliance, only if we reach our unit rate compliance by the end of the fiscal year. Has that changed for FY15 with respect to TPR hospitals?
No, and I didn't have time to get back and clarify what I said. You're absolutely correct. I did say monthly. We have it set up for monthly compliance to check hospitals. But the days of consecutive months, all that is gone. So when you get to year end, I should say fiscal year end, you will be looking in aggregate for the whole year, not by month. But the reason we are saying that it will be reviewed monthly, that's what we do. And the onus is on hospitals as well to check, because that's going to feed directly into whether we're hitting our interim and full year targets. So that's what I meant by monthly. The monthly corridors are plus or minus 5 can be expanded to 10. If you're out of compliance for the month, no, there won't be any penalty or anything imposed. It's going to be on the full year, but it's going to be very heavily weighted, looking at it for where the hospital is coming in versus their target for the year. So in that way, we are internally, and perhaps might suggest that hospitals be doing it as well. See where you are versus your interim target at December 31 and your final. Even if you get rid of targets by year end, if you're in jeopardy of not hitting that December target, that could be a problem. Does that help at all?
Yes, it does.
Okay, thanks.
Jerry Ellen, this is Mitch Lomax. How are you?
Super.
On the rate order that we received for FY14 that has our final GBR target on it, there wasn't any volume or overhead for the supply and drug rate centers. Can you speak to that a little bit?
Yeah, supply and drug, there is no more overhead and markup for supply and drugs. There's a total revenue number that's been approved, and that's going to be the norm now for most hospitals, unless you have some revenue that's excluded under this TPR agreement. So there are a few hospitals that have out-of-state revenue that is excluded, and they will have a separate calculation for supplies and drugs. Everyone else will basically be given a revenue target for supplies and drugs, and they need to comply with that.
So, and are the corridors around that the same as the other unit rates?
Yes. It's 5% on total revenue, no longer on overhead. And having said that, though, recently there was a clarification, as my understanding, put out on charging for supplies and drugs. If you're still trying to come up with a mechanism internally, the guidance on using invoice cost plus overhead and markup to hit your revenue hasn't changed. The only thing that's changed is what we are measuring the compliance again, and that'll be against total revenue.
Okay, thank you.
Hi, this is Beth again, just to follow up back on what Mitch said. If we have to change rates in the middle of the year to make the overall target, am I changing all rates in tandem? So if I have to do a 3% increase, do I do including supplies and drugs? Because supplies and drugs may not be an overcharge or undercharge like the other unit rates. It just won't work.
Yeah, at the current time, Beth, the best advice we have on that is that there's something that's an individual problem. As usual, bring that to our attention. But the underlying principle for this is to move rates in tandem. So if you have anything that you can't accomplish your revenue target by doing that, then I would send a notification to us asking for either guidance or a variance from that rule.
One of the things that we're going to be focusing on is how you're going to be in compliance either with the mid-year target or at the end of the year. So every hospital's been asked to, when they send in their data, send in where they are relative to their target and what they will be doing over the next months to get back into compliance with those targets. And we're going to be focused on those, as well as the hospital needs to be focused on staying in compliance during this time period. So what we don't want hospitals to do is after 1 month to be so far out of compliance, after a couple of months to not pay attention, and then be so far out of compliance that it's very difficult for them to try to get back in by the end of the year. So we're going to be asking hospitals to focus on compliance compliance as we will be trying to focus on compliance.
Hey, Jerry and Ellen, this is James Case from KPMG. Quick question for you. When and if you do perform rate realignment for the rate orders, when you calculate the rates on the rate order, what volumes will you be dividing by for the denominator?
At this time, we're looking to use the volumes that are on the current rate orders, and if we decide to do something different, we will notify you. I mean, we tend to have a second webinar before we start putting out the final orders for all the hospitals, and at that time we will notify you exactly what volumes we will be using. There may be a change to the volume only if that were anticipated as part of the global arrangement that we have negotiated with certain hospitals. For instance, if a hospital knows it's going to close a service or if it's going to open a new service, those volumes might be adjusted for. But other than that, we will probably be using the same volumes that are currently on your current order right now.
So if you were, sorry, just a clarification, so if you were set using FY12 volumes, you would continue to use FY12 volumes as the denominator. If you were set using FY13 volumes, you would use FY13 volumes.
Most people should be using fiscal year 13 volumes.
As adjusted under the GBR agreement.
Right. I can only think of one hospital that might go back.
Okay, thank you.
There were a number of hospitals who we took their fiscal year 13 volumes and we adjusted them because of changes that were negotiated as part of the GBR agreement. So those volumes will continue to be used.
Okay. This is Bruce at Atlantic General. I'm relatively new to this. When I listened to the lady over there talk, she said something about moving the rates in tandem. You have to, when you change rates, you don't change them at the rate center because the volumes are different within different rate centers, aren't they? So if the volumes don't move, you could have a lot of MRIs and you need to get it in compliance, so you change that rate, not all of them. Did I misunderstand?
The tandem part relates to the 5% or the request for 10%. If you have a plus or minus 5% for every rate center, you're correct. You would have between plus or minus 5% of your approved rate to charge. What we're talking about, if somebody sends in a letter and says, I need to move my rate up to 10% for these reasons, we would expect you to do it by all revenue centers. It's not like under the charge per case methodology, while achieving revenue was done just by the room and board rates for the large majority of hospitals.
Okay.
So we want this.
We're talking about the overall compliance, not the individual. If you're still trying to get in compliance with a unit rate, you would change it specifically. But if you're looking at your overall global target, you would move them in tandem.
Correct.
Okay.
Particularly if you have to move beyond the plus or minus 5%.
Got it.
Okay. This is Rich again. With respect to TPR/GBR savings or savings in terms of carrying over dollars or not with respect to the total rate order, is that to continue for FY15 or is there a cap? I understand some hospitals it differs by their agreement. Can you speak in general to that question?
The question?
That is something that's being discussed now that we have slated for the second webinar that we intend to do. And should that change and have corridors similar to what was around the target under CPC, CPE, and for TPRs it would mean the target around any savings or dis-savings, what they're used to seeing, then that would, my understanding is, require a contract amendment. And if that were to happen, that would be discussed ahead of time with all hospitals.
Right.
That's why we're on this relative fast track that time will not have gotten away from anybody before you know what your final rate order is going to be so that you can be compliant. But that is still under discussion, and that's one of the things that would require contract language change.
That is one of the things that will be discussed and will be revealed to you at the next during the next webinar.
questions at the moment. Oh, sorry.
Greg, are there any other questions out there?
Hey guys, I'm from Bonsacor. One more question. In terms of the reporting requirements in the contract, will there be any more guidance coming up in the next couple weeks on what the standard packages will look like?
I'm sorry, what the standard what will look like?
The standard submission packages, what you're looking for on a monthly basis, and metrics and those things that are currently in the contracts that are requested that we aren't currently providing now.
Right, that's a good question. That is currently under development. Right now, the only thing that we've added, and most hospitals have had it already and are reporting with it, and everyone will use the July 1st, is the GBR compliance report. For the further metrics, that's under development, and more information will be forthcoming, I'm told, very shortly. And in the interim, it will still be the monthly. It will still be the monthly reporting, the monthly reporting as you've been doing it since restating the historical, and then the GBR report. That's what's in place for now.
Any other questions? Okay, I think that may be all of our questions here. I've got a question, though, about the things that we don't know yet, like the rate realignment and the reporting. Do we think that the next webinar timing may be around late July, early August?
Yes.
Yes,
we
that's
think it'll
definitely.
be closer to late July, we're hoping. So we intend to move quickly on this because we realize hospitals want to be in compliance. We want them to be in compliance. So we have work groups looking at things, and we're modeling things ourselves. So as soon as those are complete, we will hope to get the information out to the industry so that they can be sure that they do with what we'd like them to do.
Okay, and another thing just to add, Dennis just brought to my attention, some of you may have been in discussions on this. At the next webinar, we'll also go over any new reporting requirements or procedures or record keeping necessary for denials, UCC, and shared savings, the ACOs. Those are part of the new reporting requirements that you mentioned, in addition to the other metrics. But we're trying to capture anything. So if you should think of anything, either on your own or if you want to do it through MHA, that's an outstanding question, please let us know. So certainly we can try and get it on the next one so we're all on the same page. And that would be welcome, so we're not missing something. And we're hoping that once you see everything, it may make rate setting compliance easier.
There was a question about whether you said denials.
Yes, denials, a UCC reporting, and shared savings for ACOs. And what we'll attempt to do prior to the next webinar is Dennis is attempting to get all the information and requirements out to you so that when we go over a presentation at the next one, you will already know what's going to be put in place and can have any questions ready, and we'll be more than happy to take those.
Any other questions?
Is everybody ready for a holiday?
Okay, well, we just wanted to speak to you as soon as possible. We know there was not much notice given to hospitals. We appreciate the opportunity for us to talk to you all, and in the future, we will try to notify you, give you a little more time, a little more notification on when this next one will occur. But I would suggest that it will probably be towards the end of July. So until then, Greg, do we have anything else?
There's a question here. Recent.
1 We have one more.
Question being, what is the pure cost increase of the revenue increase? That would be the cost increase would underlie the assumptions that, or not assumptions, the adjustments that are being made once we get back to the permanent revenue by reversing all the prior years, doing the permanent adjustments, and then adding on. The cost underlying, the only reason, the only place we would use that is if we go back to the cost reports and do full-blown rate realignment or some version thereof. Right now, what we're suggesting to you is that the volumes in your GBR agreement that produced your rate order are still in effect, and those resultant unit rates are what need to be used to be in compliance with the GBR target for July 1 and December 1 that will be issued by letter until such time in August we get a new rate order out, and that's when any new cost allocation would be used.
I think this is a lady who is a person who is a consultant, and the question really is concerning what the update factor contained as far as cost, as far as increases are concerned.
The update factor that was approved by the Commission, it came from Global Insights. It's the number that Medicare used to use as the basis of their cost increases. That number was approved at full inflation, 2.41%. As I said, there will be an offset to that of approximately 2%. It will be different for every hospital depending on the numbers that were sent out by Chile recently. Again, it will be that total number that's been approved for this year, less the amount that was removed from the rate structure last year. Any other questions? Okay, hearing no other questions, we're going to end this now. Thank you for your time and attention. And if you have any questions, once you get the information sent to you, please notify us as soon as possible so that we can get an answer back for you and then get a notification of what your global budget will be for the year and for the 6 months ending December of 14. Once again, thank you for your time. And that's a wrap. Great.
Thank you, Sherry, and thank you, Ellen.
Okay, bye.
Dennis.